Check the voice. Good evening to everyone and welcome to today's session. Yesterday we had a slight interruption when we started the topic of laryngeal carcinoma. So today is a sunny day. Few days are rainy days. So we welcome our online students Dr. Tarachan, Purohiti, Dr. Agarwal, Tejus, and the students from Vijayawada, Vizag, Guntur, Jabalpur, and Nainital. So, cancer larynx. If at all 10 questions come in the MD entrance in ENT, invariably there is a question on the laryngeal carcinoma. It is 10 times more common in males than in females. It is typically seen in the age group between 40 to 70 years, which is one of the common form of question which is being asked. Now, what are the risk factors? You all know very well. It is the tobacco and alcohol which are considered to be the most important risk factors. And in the cigarette smoke, it is the benzopyrene which is considered to be very carcinogenic in nature. Individually, alcohol or the smoking by itself will increase 2 to 3 folds risk. But the combination of these two is nearly around 15 times more riskier is what need to be remembered. Similarly, any previous radiation or a laryngeal papilloma, it can also induce laryngeal carcinoma. The risk factors you need to be very, very sure about. Similarly, can laryngeal carcinoma be an occupational disorder? Is my question to all of you. A lot of people use asbestos as the tiles on the top of their house. Asbestos, mustard gas and petroleum products, they are known to have a role in induction of the laryngeal carcinoma. Now, what is the challenge of this topic? Laryngeal carcinoma is my question to all of you. Our entire ENT posting, nobody will show us anything. Why? Because mouth is deep, nose is deep, ear is deep. There are those deeper structures on which the Department of Otolaryngology stands on. So first 1 week we will always be sincere and honest students, we wanted to learn. But within about 1 week, 10 days, we lose an interest and we hang around the canteen and ENT posting is over in MBBS. So everything else goes into imagination. So that's the reason, doctor. Anatomy of the larynx is most important thing to understand the staging, etc., in laryngeal cancer. So we have supraglottis, we have suprahyoid epiglottis, infrahyoid epiglottis, epiglottic folds, arytenoids and ventricular bands, which are the false cords. They constitute what is called as supraglottis, is what you need to basically remember. Now, if you look at the typical structure, here you have epiglottis, the epiglottic fold. You have the arytenoid cartilages. Then here you are having the vocal cords, and we have the ventricle of Morgagni. Here you are having the false cords. So above the level of this vocal cords you have supraglottis, at the level of the cords you have glottis, and below that you are having infraglottis and subglottis. And here you have the cricoid cartilage, which is a part of the subglottic space. This is another important view which you need to basically understand. One of our online students, Fahima, transmission is not good, but I think she need to check the local connection, because local connectivity speed must be at least 1 Mbps. So, epiglottis, hyoid bone, false cords, true cords, and subglottis and cricoid cartilage. Now, this is a typical laryngeological view which you need to be quite sure. Here you are having the true vocal cords. So when you do intubation, what is important to be very sure that you pass an endotracheal tube into the trachea only. You see the cords when you lift the epiglottis. Then you have the arytenoid cartilages, and here you are having the epiglottis is what you are able to see. Now this is a typical picture where you can see the presence of the malignant tissue, which is the adherent to the vocal cord, is what you are able to see. Then this another important view where you can see the arytenoids, epiglottic folds, the epiglottis, the vocal folds and ventricular folds is another view. Then this is a T1 staged carcinoma of the supraglottic area above the vocal cords, which are able to see very clearly. This is how a cancerous tissue of the larynx typically looks like. Once more, this another view when the vocal cords are closed versus when the vocal cords are in an open state. So when they are in an open state, these are the true vocal cords which are able to see, and through them you can see the trachea. And this is the false vocal cord. It is a concept very similar to labia majora and minora kind of a similarity, where you have the false vocal cord and the true vocal cord is what you are able to see. Now, doctor, glottis, typically the level at which the vocal cords are present, including the anterior and posterior commissure, basically constitutes what is called as the glottis. Now, subglottis basically extends below the level of the vocal cords until the lower border of the cricoid cartilage is what you have to fundamentally remember. Now, the most challenging question which is frequently asked in the exam, you please check whether other people transmission is it okay or not in Tirupati, Guntur and all. So, alright doc. TNM is whether it is breast cancer or laryngeal cancer or any cancer is tumor, tumor size, nodal status and metastasis. Tumor size, typically you have T1, if you take supraglottis, basically TNM we need to learn for both supraglottis, glottic and subglottic area. Yes, in the supraglottis, we say T1 when tumor is limited to one subsite of the supraglottis with the normal vocal cord mobility, then you call T1. You call it as T2 when the tumor is invading the mucosa of more than one adjacent subsite of the supraglottis or the glottis or the region outside the supraglottis, which can be the vallecula or the mucosa of the base of the tongue or the medial wall of the pyriform sinus without any fixation of the larynx. Then when do you call it as T3, doctor? T3, you can turn the fan that side so that you will get a little relief. Alright. T3, when do you call it, doctor? Typically, when the tumor is limited to larynx with the vocal cord fixation and it is invading any of the structures in the supraglottic area, which can be postcricoid, pre-epiglottic, paraglottic space or the thyroid cartilage. If any of them are all invaded, then you basically call it as T3 is what need to be remembered. Now, I'll show you one classical laryngological example. In this patient, there is an extensive vocal cord involvement covering most of the left vocal cord. It has in fact is extending into the right vocal cord also. This is an example of how a T2N0M0 basically looks like. Then this patient, he had surgery, he had no recurrence, his voice remains normal. Can you turn this fan that side so that they will have, no, this one, yes. Now, after using the laser and ablating the cancerous tissue, this is a typical appearance without any recurrence after about 3 years. Especially in the early stages of the laryngeal cancer, if you are able to use the laser therapy, it has got a wonderful effect of extirpating the malignant tissue with very minimal recurrences. That is the importance of identifying it much earlier. Now, what is meant by T4 in the case of supraglottic cancer? Each of these stages we need to know: supraglottic, glottic and infraglottic cancer. T4 may we have T4A and T4B. The tumor is invading the thyroid cartilage and also the tissues beyond larynx, which can be trachea, soft tissues of the neck, extrinsic muscles of the tongue, strap muscles, thyroid or oesophagus, any of these structures. You call T4B if it is also involving prevertebral space and it encases the carotid artery, or if it is invading the mediastinal structures, you call it as T4B. Now the question comes to our mind: so many cancers are there in medicine: prostate cancer, breast cancer, laryngeal cancer. Is it humanly possible to remember all these cancer staging? It is not needed for entrance. For entrance, MD entrance, breast cancer, carcinoma cervix, endometrial cancer. If you say ENT, laryngeal cancer, the whole challenge is in remembering the staging when you go to the entrance exam. So suddenly if he says that it is encasing carotid artery, T4B should strike to you. Suddenly if he says that it is involving trachea and soft tissues of neck, T4A should strike to your mind. Now let us look. Earlier days there is more imagination, but imagiology, CT, MRI have improved so much that nowadays diagnosis, to prove your diagnosis, to stage a malignancy is much more easier. So this is an example of a T1 and T2 weighted MRI coronal images where the tumor tissue you can see is typically replacing the normal structure of the vocal cord and giving you the typical appearance. This is the typical malignant tissue. Even you can see the malignant tissue which is invading. Then you can see this is a pre-epiglottic space. Normally it is filled with fat, but in this case of the laryngeal cancer, you are able to see the infiltration to preglottic space. Then let us talk about the glottis and its classification. If the tumor is limited only to the vocal cords always mean either a anterior or posterior commissure, but there is a normal mobility, you call it as the T1. In that, if it is involving only one cord, it is T1A. Both the vocal cords you call T1B. From the glottis, if it going to supraglottis, then you basically call it as T2, even if it is going to subglottic area. And if it is only there in glottic area, but there is a loss of the vocal cord mobility also, it becomes T2, is what need to be remembered. Now doctor, between glottic versus supraglottic malignancy, what is the main difference? Vocal cords don't have lymphatic drainage. So if there is a cancer in the vocal cords, there is no SMS going anywhere. But if there is a cancer in the supraglottic or infraglottic area, there is an SMS, blogs, Twitter, everywhere the news will go, and all tissues will say, send us also some more cancer. So they carry a poorer prognosis that way. Then T3, it is limited to the larynx with a vocal cord fixation, or if it is involving the paraglottic space, or if the thyroid cartilage involvement is there, even minor, then you call it as T3. Now let us see. Typically, this is a left supraglottic carcinoma which is invading the paraglottic space, and the paraglottic fat is being replaced by the malignant tissue. And if you look at the arytenoid cartilage, this is the arytenoid cartilage. Normally, it won't be this much a high intensity one, but it has undergone sclerosis because of the invasion of it. So, invasion of the cartilage changes the staging of the carcinoma of the larynx. So, three characters we should see. Typically, is it affecting vocal cord mobility? Second, periglottic spaces, are they involved? Third, is it involving the thyroid cartilage? So, these are the important areas which we need to be focused more. This is another example where you are able to see the invasion by the malignant tissue of the thyroid lamina on this side. There is a malignant tissue involving the thyroid lamina. So, the involvement of this cartilaginous structure makes the staging altogether different. Now, doctor, what is T4A, T4B in case of glottic cancer? The tumor is invading through thyroid cartilage, going beyond the larynx, T4A, involving prevertebral space or mediastinal structures, you call it as T4B. Now, once more, this is another example of a glottic tumor which is typically involving the periglottic space and also invading the surrounding cartilage, which makes the stage altogether different. Now, doctor, what is the story of regional lymph node involvement? How do we grade it? T and M. No regional involvement, N0. Single ipsilateral node, 3 centimeter or less. So, what is the golden figure which we need to remember? It is 3. The value 3 is very important. So, we have the students in Davangere who are asking us what are the today's topics of discussion. I think they logged in a little late. Today we are going to discuss laryngeal cancer. Otosclerosis is another important topic, and 3 to 4 relatively minor topics. And tomorrow we will discuss CSOM and the complications of the CSOM and ASOM. And on Friday we have all the miscellaneous topics, around 10 to 15 miscellaneous topics. And on Saturday we will have a subject test along with discussion. Okay, doc? Now, suppose if a single ipsilateral lymph node is involved more than 3 centimeters in size but not more than 6, you basically call it as N2. Or if multiple ipsilateral lymph nodes, none more than 6 centimeters in greatest dimension, N2. If bilateral or contralateral lymph nodes, none more than 6 centimeters also, you call it as N2. Accordingly, you have N2A, N2B, N2C. I leave it all to you in the literature, but 3, 6, 3 to 6, more than 6, these are the numbers. Because examiner has a love for giving 5 centimeter is the ipsilateral node. Then suddenly it should strike to you, whether it is N2A, N2B, N2C. Then you have N2, you have N3 where it is more than 6 centimeters is the lymph node size. Then no metastasis, yes metastasis, will make it M0, M1 like anywhere else. So this is how you have got a early stage 1, stage 2 invading the surrounding cartilage also, stage 3 surrounding tissues also, stage 4 going to multiple mediastinal lymph nodes. This is how we basically stage it. Now, doctor, a very, very frequently asked question in the exam, what is the typical histology? Squamous cell carcinoma is the most common type of the histology, is what you need to answer without any second thought. Generally, when the vocal cords are involved, person develops hoarseness. So his wife will say, nowadays your hoarseness is not coming down. I read in the newspaper or google.com that it can be cancer, please go to the doctor and tell me that good news, so that I'll call the insurance guy. So chordal lesions, because of the hoarseness, or the people come running to the hospital and they are evaluated and you catch them early. Supraglottic cancers, they basically grow to a bigger size, hence when you detect them, they are typically in an anaplastic stage. Now let us talk few comments on each of these. Supraglottic cancer. Supraglottis has so many structures, no? So naturally entrance exam questions are, out of these 10 structures in the supraglottis, which is most common? What is your answer? Epiglottis and false cords most commonly are involved, followed by epiglottic folds is what need to be remembered. Then typically when there is infrahyoid area epiglottis involvement, or the ventricular band, if it gets involved in the supraglottis, then the malignancy has a greater chance of perpetuating into pre-epiglottic space and invading the thyroid cartilage. So that is the reason these two are the bad locations, where the tumors in this location have a greater chance of landing up into T3 and T4 stage. Then the nodal metastasis. In supraglottic they occur very early, unlike the glottis where there is no drainage. Then which nodes are most commonly involved, doctor? It is the upper and middle jugular lymph nodes are the ones which are more often involved in supraglottis. And epiglottis has a speciality. If there is a malignancy in that, bilateral lymph node involvement is more common among the supraglottic structures. And most of the time, the supraglottic growths are often silent, unlike the glottic cancer, which lead to hoarseness of the voice. Hoarseness is a late symptom in supraglottic cancers. Now, naturally, the examiner's favorite question is, what is the most common presenting feature of the supraglottic cancer? So, it is the pain in the throat, dysphagia, referred pain, or a mass of lymph node in the neck. They are the common presenting features. Of course, patients can also have respiratory obstruction, halitosis, weight loss. They are all the late symptoms. Then coming to the glottic cancer, what are you going to remember, doctor? In most of the cases, if you take supraglottis, glottis versus infraglottis, the most common location between these three is the glottic area. And it is the free edge and the upper surface, not the under surface of the vocal cord. And typically in the anterior and middle third of the vocal cord is the most common location. These words you need to remember with double emphasis. Why? Because the examiner has a chance of asking, is it a free edge or a married edge? Is it the upper surface or under surface? Is it the posterior third or anterior third? Anything can become the suspicious ways of a question being framed. That's the reason. Now, doctor, a glottic cancer can lead to fixation of the vocal cords. If the vocal cords got fixed, let us say, what does it indicate? When will they get fixed? The moment the glottic cancer goes and invades the thyroarytenoid muscle, then the fixation of the vocal cords will occur. And often the presence of fixation of vocal cords with loss of mobility, when you examine through the laryngoscope, is an indication of poor prognosis, is what need to be remembered. So this is an example of the laryngeal carcinoma. See, doctor, earlier days learning is very difficult. Somebody should show and you have to see. Present day learning is very easy. Go to Google, you have thousands of Google images. Go to YouTube, you have actual acoustic neuroma operated, laryngeal cancer operated, and different stages of the laryngeal cancer, patients talking about their life's experience. Everything is available on the net. So there is no need of sitting in a reading room in a dark light and underlining the books and then frustrating. You have got everything available. But sex, swimming and surgery, they can't be learned only by watching. So you need to practice. So that's the reason you need to go to hospital, see the patient. One patient story, if you listen, you will never forget in lifetime. So doc, hoarseness of the voice is an early sign of the glottic cancer. And that's the reason it is detected very early. And since there are no lymphatics, it doesn't metastasize and it is detected in a very early differentiated, well differentiated phase. And if there is any increase in size, the fixation of cords can occur, and when that occurs, there is a development of laryngeal obstruction and stridor. Now this is another coronal reformation image on a helical CD, where the right glottic tumor, typically you are able to see, and this is an example. This tumor is no more limited only to the vocal cords, even the subglottic space also it is invading, which is delineated very well. At the time of endoscopy, only the glottic involvement was seen. But later on, when the MRI had been taken, you are able to see even the subglottic invasion, which altogether changes the prognosis and the staging of it. This is an axial CD, where you are able to see the malignant tissue typically is having extension and involving the cricoid ring. Once more, a cartilaginous invasion is a bad omen. Now a few comments on subglottic cancer. Typically subglottic cancer, subglottis in the case of the children, infants is narrowest part. In adults, what is the narrowest part, doctor? Glottis. Right? That's what we studied in the last session in anatomy. So the earliest presentation of a subglottic malignancy is a laryngeal obstruction, and often it presents late, and by the time of detection only it's spread already. Can you give me a similar kind of a tumor in case of bronchogenic carcinoma? Small cell cancer, histology in bronchogenic carcinoma, by the time you detect only, already adrenals, everywhere metastasis happen. Small fellows run faster, right? So that's how a small cell carcinoma metastasizes, and by the time of diagnosis only, it is already metastasized, is what you will be able to identify. Now, how do you diagnose laryngeal cancer? Typically, anybody who is in the malignancy age, what is malignancy age? Sweet 40s, 40 to 70, with the hoarseness of the voice extending beyond 3 weeks. As a teacher, I am always afraid whenever I have a hoarseness of voice. On Friday and Saturday, we are going to have an excellent teacher, Dr. Srinivas Murthy, who is our very good friend in medical school days also. He is an ENT surgeon who will be honoring the session of delivering some of the topics on Friday, Saturday. Every day to see same Dr. Murali Bharadwaz is a boring job. So you have got a different teacher, you will get a different appetite for learning. So I requested the doctor, Dr. Murthy. So every time I get a hoarseness of voice, he reassures me, don't worry, it is not cancer, still there is some more time. It is a laryngitis because of the common cold. So I am little more assured. For a few days, I will go into mount breath, and after that it becomes all right. So for a physician and a teacher, to not be able to talk is equal to hung to death. So that's a problem. Now, doctor, Carcinoma-in-situ and superficial carcinomas, they need to be basically differentiated from a leukoplakia, which is not yet malignant. So for that, we basically use the toluidine blue staining, which will be able to differentiate where carcinoma-in-situ will take up the dye, but the leukoplakia does not. That's how you can be able to differentiate, and from the selective area you can take the biopsy. Now, doctor, we come to the most important area frequently asked as an MCQ. We welcome our online students, Dr. Vinod, Akshara, K for what? K for Kakinada or Karnool? So now we are a very big community with nearly around 100 plus students attending the session today. So you all are given the notes. Whatever we teach, we broadcast, we offer it as a notes. So take a chance after going home to run through notes. You will discover that 100 or 150 pages in the textbook are covered. So you will, but for you yourself to read that will take a little longer time. That's only difference. So we need to leverage the time by coming here to get focus. Now, doc, any malignancy, surgery, radiotherapy or chemotherapy. So which one do you want to choose? Radio, surgery, or conservative laryngeal surgery, or a radical total laryngectomy between the two? Or do you want to do both surgery and radiotherapy? Not much for place for chemotherapy. Now, doc, any squamous cell carcinoma anywhere in the body highly responsive to radiotherapy. That's a very important rule which you need to remember. So for early lesions which are not impairing the cord mobility, which are not invading the cartilage, which are not involving the cervical lymph nodes, treatment of choice is radiotherapy. Recently we had a APPG 2013 exam, classical question. In the early stage of the laryngeal carcinoma, still the vocal cord is not involved. What is the treatment of choice? Radiotherapy. So as I told you, out of 10 questions, whether it is NEET PG or state PG, one question on laryngeal carcinoma invariably will come. Now, doctor, there is a malignancy of the vocal cord. There is no loss of mobility. You have given radiotherapy. Why you are biased for radiotherapy? Because it will retain the voice. 90% cure rate is there. It's altogether good for the patient. He is a happy man. Then, if it is a superficial exophytic lesion, or if it is typically there in the tip of epiglottis and epiglottic folds, radiotherapy especially has a role. Such lesions are more amicable and their cure rate is between 70 to 90%. So this is how you are sending the patient to radiotherapy with the early stage of the laryngeal cancer, where the vocal cord mobility is still intact, is what you are going to remember. Now, in what scenarios radiotherapy doesn't help? Fixed cords, subglottic extension of a glottic cancer, invasion of the cartilage, or if there are nodal metastases, they become an indication, if any of these things are there, for surgery instead of radiotherapy. So always when a question is being asked in the entrance, you must look for where are the buzzwords. If these buzzwords are there, don't go to radiotherapy as your answer. That's what the examiner wants. Now, what kind of surgery you want to basically do for this clinical scenario? You have conservative surgery where voice is retained. So in this, what will you do? In a conservative surgery, you will excise the vocal cord after splitting the larynx, which is called cordectomy. You excise the vocal cord and anterior commissure also. Then you call partial frontolateral laryngectomy. You excise the supraglottis, which include epiglottis, epiglottic folds, false cords and ventricles, but not vocal cords. Still the voice is retained, na? Hence it is still called conservative surgery. Then you give a transverse section of the larynx above the vocal cords. You call it as partial horizontal laryngectomy. Now let us see few pictures on how the things go on. See, you have a tumor, doctor, which is invading the vocal cords, and typically it is having a extension into the subglottic area also. So in this, what you have done, you have basically resected a part of the vocal cord, and then you have transposed a graft in order to maintain the continuity. So this is an example of a left cordectomy with reconstruction. It is an example of a conservation surgery where the voice is conserved, right? Now, this is an example of a superficial cancer of the right vocal cord, and you are basically treating it by doing a cordectomy. What kind of cordectomy it is called? Vocal cord and the surrounding muscular tissue. So it is basically called transmuscular cordectomy is what you are basically carrying out here. So this is a typical example of how the vocal cord along with the surrounding muscle tissue is also being removed. Then this is an example of a T1A cancer of the left vocal cord. And what are you doing it over here? It is infiltrating the vocal ligament. So here you are doing a complete cordectomy is what you are fundamentally doing. So this is a typical operative area where complete cordectomy is carried out. Then there is a superficial tumor of the laryngeal side of the epiglottis, and here what you are doing, doctor, we are doing a medial supraglottic laryngectomy without the resection of the pre-epiglottic space. So they are the various methods. Once more to summarize, we have mainly a supraglottic laryngectomy, and in this what do we remove in case of the supraglottic laryngectomy? We remove supraglottic portion of the ipsilateral thyroid cartilage, supraglottic larynx including epiglottic folds, false vocal cords and epiglottis is basically called supraglottic laryngectomy. And in order to carry out this procedure, the supraglottic laryngectomy, the most important prerequisite is the person's pulmonary reserve in the lungs must be adequate. That's very, very important. Then we have the next important procedure which is called total laryngectomy. It is not a conservative surgery. Why? Because the person is losing the voice. So we remove the hyoid bone, pre-epiglottic space, trap muscles and one or more rings of trachea, even they are also removed. And the pharyngeal wall we repair, and the lower tracheal stump, because you are removing a, see finally larynx is going down and becoming the trachea. So you are removing the entire larynx means trachea is left. Now what will you do with that? Typically it is being sutured to by making a hole to the skin. So what is left? The person is left with no voice because no vocal cords are there, and there is a permanent tracheostomy stone which is being left over. And a good number of times this is done for a late stage of laryngeal cancer. Generally these late stages involve the regional lymph nodes. That's the reason we also need to combine the block dissection of the nodal metastasis along with the total laryngectomy. It is also combined. So you can see here, we are having the vocal folds, we have the larynx which is continuing down into trachea. And trachea ke piche kya hai? Epiglottis. Nose is front, mouth is behind. No doctor. Mouth is becoming esophagus and nose is becoming trachea. Excuse me for such a crude teaching then. Because as a MBBS students, I used to have a wonderful imagination that esophagus is front, trachea is behind. So one of my friends said, nose is before, mouth is behind, don't you have that much a minimum common sense? So from that, then onwards, anytime I teach, I make people remember, assuming they don't know. I know, you know very well. So this is the trachea. After removing larynx, it is made open into a tracheostome. Now doctor, in which scenarios the total laryngectomy is indicated is a very, very, very important question which you need to answer. T3 lesions, it is indicated where the cord is fixed. T3 can be without cord fixation also, but whenever cord is fixed, T3B or C, whenever all T4 lesions without exception, we do total laryngectomy. Any invasion of thyroid or cricket cartilage, indication for total laryngectomy. bilateral arytenoid cartilage involvement, total laryngectomy. Anterior commissure को छोड़ दो, vocal cords को छोड़ दो, posterior commissure involve हो गया तो glottic cancer में indication for total laryngectomy. Transglottic cancer, it is no more limiting in LKG, it is going to UKG, first class, second class also. It is pervading through multiple areas. Then we want to do total laryngectomy. And if already distant metastases have developed, adrenals, liver, other places are involved, contraindication for total laryngectomy is what you need to remember. Now, is there any role for combined therapy? Yes, sir. Surgical ablation can be combined either with a pre or a post-operative radiation is what we need to remember, especially by doing so, if you combine, you can decrease the recurrence, and if pre-operatively if you give radiation before surgery, then you can also make the fixed nodes become resectable. So that is another important specific indication. Now, doctor, we have a special scenario, a patient with glottic cancer who is having carcinoma-in-situ. What do you want to do? Typically, you can do transoral endoscopic CO2 laser therapy is typically indicated. One is you can use radiotherapy is one choice always available for you. But in the modern times, we have the CO2 laser therapy which is available. So, doc, this is a classical example. Pre-operatively patient who had a vocal cord early lesion, after laser therapy, post-operatively within 2 months, clean shave, no recurrence. Similarly, you have one more case of a pre-operative view, laser therapy, post-operative view. Similarly, this is another example. On this vocal cord, you have a cancer, post-operatively, after laser therapy, it became clean. So, in exam, at least if you can remember, laser therapy is used, I will be more than happy. Then, if laser is not available, you are working in CHC, Community Health Center. You can do under microscope stripping of vocal cords is a choice which is available. And that stripped tissue is being subjected to biopsy. And if it is showing the invasive cancer, then that becomes an indication for radiotherapy. And suppose if it is saying only carcinoma-in-situ, you can ask the patient to come for follow-up. So let us summarize, based on the staging, how do we want to fundamentally manage? We have carcinoma-in-situ and invasive carcinoma. Within invasive carcinoma, we have T1 different stages, right? So it is a T1 carcinoma in glottic area. It is a radiotherapy which is a treatment of choice. T1 carcinoma going to anterior commissure, still radiotherapy is the best choice. Suppose if it is not feasible, then we need to do frontolateral partial laryngectomy, which is an example of conservative surgery. If it fails, then total laryngectomy should be done. Then T1 carcinoma going to arytenoid, then what do you want to do? Because each of these clinical scenarios is an MCQ in the entrance. T1 with arytenoid, T1 with anterior commissure. So you have to be 200% sure answering in the tomorrow's exam. Not very big deal. 2 to 3 times you imagine different kinds of patients who come to you. Then what you want to do? So as entrance going students, we used to play this game. Make 3 or 4 classmates bakras and they tell, I belong to T1B, what do you want to do? Just like dumb charades. So ultimately, those classmates have now become top specialists and top cochlear implant surgeons with whom we played in the anatomy, physiology, biochemistry days to break the monotony fundamentally. So T2N0, it typically implies the tumor of the glottic area, that is vocal cords, anterior commissure, vocal process of the arytenoid with the extension to supraglottic and subglottic area. Then how do you want to manage? This is one favorite question of the examiner. T2N0. T1 is simple. T1 may you have got extension to anterior commissure, T1 with extension to arytenoid and overall radiotherapy is the treatment of choice. वो हो गया ना glottic cancer में. Lot of questions where they come is on T2N0. Why in T2N0? Either you can do a conservative surgery to retain the larynx with a risk of recurrence, or you can do a total laryngectomy with the loss of voice. You have to accept one pros, one cons. That's the whole challenge. Now let us take up the debate. The treatment of T2N0 in the glottic cancer depends on two important factors. Is the vocal cord mobility is still there or is it impaired? Factor number one. Is there any involvement of anterior commissure or arytenoid? Is the second thing you want to check when you do the imaging. Now, if the cord is mobile, vocal cord, anterior commissure and arytenoid are not involved, what do you want to do, doc? Radiotherapy gives the good result. After radiotherapy, if it recurs, then total laryngectomy. Then, suppose if radiotherapy fails, some surgeons love to reserve the voice of the people, and still they take the risk of doing partial vertical laryngectomy and still retain the voice. Second scenario, T2N0, anterior commissure and the arytenoid are involved and the cord mobility is lost. Then what do you want to do? No radiotherapy, sir. Because if you do radiotherapy, you may ask me a question. What is there, sir? We will try radiotherapy. If it fails, then we can try laryngectomy. But if you do radiotherapy in a scenario where arytenoid, anterior commissure, etc. are involved, it will lead to perichondritis. And the presence of perichondritis will give difficulty to do total laryngectomy at a later point. So that is the reason what we do is a conservative surgery like vertical hemilaryngectomy or a frontolateral laryngectomy and try to retain the voice. So that's what we do. Then at the time of doing a conservative laryngectomy like vertical hemilaryngectomy, you may get a doubt. Shall we do the block dissection of the nodes or not? Generally T3N0 means it did not involve the nodes. So unnecessarily there is no necessity of removing regional nodes. Once more, this is an important area where question comes. Will you do vertical hemilaryngectomy with block dissection, without block dissection? Since it is T3N0, we don't want to do the block dissection of the surrounding lymph nodes. Now, suppose if the cord mobility is affected in case of a T2N0 lesions, we need to be definitely sure on what we are doing between radiotherapy versus conservative laryngectomy versus total laryngectomy. If there is a normal cord mobility means it says that the growth is only limited to the surface of the vocal cord. But if there is a impaired mobility means there is a deeper invasion into the intrinsic laryngeal muscles, and any cord immobility indicates a deeper invasion. Any deeply invaded malignant tissue will be radio unresponsive. So if cord immobility है तो रेडिएशन देना या नहीं वो सोचने की जरूरत भी नहीं है, क्योंकि it won't be radio responsive if the cord mobility is gone. That is the rule of thumb. So this is once more an example of a near total laryngectomy in advanced cancers of the larynx, where you are leaving a permanent tracheostomy. But how does it differ from that of a total laryngectomy? You are preserving some amount of voluntary voice in near total laryngectomy. How will you preserve that? Typically, If you look at the technique, what are the structures which are being removed in the near total laryngectomy? I leave the pictorial for you to review. But what is important for you to do near total laryngectomy? At least one arytenoid must be free from the cancer. Then you will be doing what is called near total laryngectomy is what need to be remembered. Suppose if the patient doesn't have a good pulmonary reserve, then we do what is called total laryngectomy and then open a tracheostome is what need to be remembered. And near total laryngectomy, what do you remove? You remove the thyroid, cricoid, as well as the hyoid bone. They're all being excised along with the larynx. So that's what you do in the case of the total laryngectomy. Then this is an example of a supracricoid partial laryngectomy along with cricohyoid pexy. Basically, what is the purpose of doing all these arthrodesis? The idea is to preserve the voluntary voice as much as possible. So that is what we are trying to do. Now, doctor, suppose if there is an invasion of the glottic cancer into paraglottic or subglottic space, then there is a concomitant invasion of the laryngeal cartilages also. So that is the reason they have a poor survival, and in such cases if you do radiation, if the cord mobility is impaired or if there is a subglottic extension, drastically the survival will fall down from 86% to 63% is what need to be remembered. So that is all the discussion about T2N0. T2N0, the treatment depends upon what are the two factors, two most important factors. How is the cord mobility is the question number one. Cord mobility is the question number one, and is there any involvement of arytenoid or antecommissure is the question number two. Then what are the choices available in T3N0? Is it a voice conserving laryngectomy or a voice losing laryngectomy? Between the two, they are the things that need to be basically answered. And the moment there is a cord immobility, radiotherapy is useless. They're the important dictums that should not be forgotten. Now, doc, T3 and T4 glottic cancers, how do you want to fundamentally treat? Total laryngectomy is always the choice, and it is generally combined with a neck dissection of the regional lymph nodes. And in T4 lesions especially, you need to give both surgery and also radiotherapy as a combined option. So T1 is easy to remember because radiotherapy. Few cases may partial voice preserving laryngectomy. T2N0 may, depending upon the cord mobility and arytenoid invasion. T3, T4 may, T4 is a combined therapy. T3 is basically by total laryngectomy. So these are the points that need to be remembered. So this is one important diagnostic algorithm on which a lot of questions are frequently asked, doctor. Very good. Our numbers have increased with Dr. Rashid and Dr. Kavita along with Dr. Akshara joining us. Now T2N0. So this algorithm you need to remember, because in tomorrow's exam this becomes a bottleneck. Cord mobile, this is already what we discussed. Just a summary. Cord mobile, cord immobile. Involvement of the antecommissure arytenoid or the cord is immobile. Then we do conservative laryngectomy. If it fails, then total laryngectomy plus neck radiation. Then cord is mobile. Then radiotherapy is the main treatment with the radiation to the upper neck nodes. If it fails, conservative laryngectomy. If it fails, total laryngectomy plus or minus neck dissection is what you need to remember. Finally, what is left? Subglottic cancer. Unfortunately, it is metastatic by the time you treat. Very rare, unless you are personally a doctor and you discovered it very early, or you are an apprehensive patient and went to the clinician early, subglottic cancers won't be detected that early. If they are detected, T1, T2, radiotherapy can be given. But T3, T4, they need combined therapy, total laryngectomy along with post-operative radiation. And that's all the main part of the treatment. So that brings us to the conclusion, doctor. So what are the main buzzwords which you will remember when it comes to the laryngeal cancer? The staging, the choices between surgery, radiation, partial versus total. I have left most conservatively in about 10 pages the notes. You can further filter it, because last moment of exam, hardly if you can remember where is T2, where is T3. You have so many T2, T3s in multiple malignancies throughout our body to be remembered. So that is the reason out of the notes given, 50% you can cut down because you understood it. 30-40% of the notes which is being given to you contains forgettable, revisable part. Make a bookmark while reading where these are the points, possibly I may forget, but I should not kind. Last moment you can revise only them and go to the exam. 2 minutes will be out of video in order to take a backup of the previous lecture.